tonight's topic. I chose the topic of cluster headaches for both the reasons of diagnosis and some of the newer treatments that we have available, and also the other trigeminal autonomic cephalgias. And that will make sense. That's a big mouthful, but will make sense as we go along and have that discussion. So we will move forward. The first thing I'd like to say about cluster headache, this is a cartoon from Edgy Medicine, and it does express, I think, a lot of the feeling patients have who have a diagnosis of cluster, in that it's an excruciatingly severe pain, occurs on one side, anywhere from 15 minutes to typically up to 3 hours per attack. So it's pretty significant. It's also known basically to have this one-sided tearing, runny nose, runny eye, sometimes a smaller pupil, sometimes a drooping eyelid. And we'll talk about a little bit of treatment with both medications, oxygen, and how we move forward with treatment. So the first thing is to make sure we have the diagnosis established. And I will tell you that it's not uncommon for patients who have a diagnosis of cluster to see likely more than 4 providers before they have the diagnosis. I think it's getting better because of more acknowledgement about the headache, but in general, patients tend to be men. They tend to think it's maybe related to a sinus disease, so they might see their primary care, they could see an ENT, and really working up to that point of getting a diagnosis. So as I mentioned on that first slide, it's a one-sided headache. It's usually above the eye or supraorbital, can be in the temple, but really the duration is anywhere from 15 to 180 minutes. And that's typically the duration when it's not treated or unsuccessfully treated. The other thing that we notice that happens in cluster, is the conjunctival injection. So meaning that the white part of the eye gets red, it runs or tears. You may get congestion in the nose. You could have running of the nose. You could even have a puffy eyelid, sweating of the forehead and face, or as I mentioned earlier, a small pupil or miosis and a droopy lid. I think the key behind this headache type is the fact that patients are often restless or agitated. So this is not the migraine of somebody who wants to go to bed in a dark room and say peace out. I think the key behind this headache is also that it's known as a suicide headache. One, likely because of the male predominance, and the success of treatment if they don't have the diagnosis is very, very low, and the pain is excruciating. There's 2 types of cluster. One, of course, is episodic, and that's the most common phenomenon, in that you get a 2-week to 3-month duration, but it can be anywhere from as short as 7 days up to a full year. But typically there's respite of about 3 months in between. The chronic cluster, however, occurs for at least a year or longer without any remission. And the remission, if you have it, is less than 3 months. So you can imagine if somebody's having anywhere from 8 episodes a day, 15 minutes to more than 3 hours, which is essentially the full day of this kind of pain. And so I think it's important, as we talk about what the clinical presentation or the patient story looks like, it is very typically a seasonal phenomenon, in that spring and fall tend to occur the most often. As I mentioned before, the minutes of duration, but also patients have the attack at about the same time most days. Obviously, in the nighttime, it has to do with also the circadian rhythm, typically within 1 or 2 hours of falling asleep. We feel like the hypothalamus, which is the organ in the brain, which is essentially the body's biologic clock, is responsible. This suggests that there's an overactivity in this part of the brain. It's why that agitation, people want to get up, they want to pace, take a hot shower, and that's very different than the migraine. So when we think about this overactive hypothalamic response, you look at it from a standpoint of a more rapid heart rate, increased blood pressure, perhaps the body temperature rises. It can also, from sweating, then chill and get cold. Sleep cycles, we know there's a release of both melatonin and serotonin from the superior hypothalamus. And then the other part is obviously that affects emotion and behavior. We also look at that flushing sensation. You might get hypermotility of the gut. So you might have this all of a sudden, oh my gosh, I have to use the restroom. You may see more sweating. So all kinds of things within that neurotransmitter release can occur. The histamine response is likely one of the other neurotransmitters that's released, and that's why we get some of this congestion, and you think about sinus infections or allergies happening at the time, and why sometimes patients don't get the right diagnosis. But we certainly know that the nerve pathways that are in the base of the brain also affect this entire construct of the autonomic reflex, causes pain and a whole host of other symptoms. That trigeminal nerve, which is the fifth cranial nerve coming out of the base of the brain, is responsible for this facial sensation as well. So oftentimes when we talk about the trigeminal nerve, it has three branches, the first division, the second, and the third division. And most often this cluster occurs around the first division of the trigeminal nerve. When that nerve is activated, then you can also get eye pain. You get the change, or what we call Horner syndrome. And that's where you might get this disruption along the nerve pathways, where you can get narrowing or smaller pupil, and you can get a little bit of that lid droop. So that's what that looks like on a picture. As I said when we first started, men are typically 4 times more likely than women. Patients who smoke may also have a higher, about an 80% increase of people with cluster have smoking history. Alcohol can also trigger attacks if you're at risk for cluster. So if you drink alcohol and don't have cluster, it's not meaning that you're going to get clusters. It's that they travel together. And so that's one issue that I often have patients tell me that they've just quit drinking because it's not worth it for the cluster attack. In between, if they have remittance, then they maybe get by, they would say, with a drink or so, but never to excess. It's also interesting, just like we see in migraine, that there's a family history or possibly a predisposition to get cluster headache. So some of the exciting things that have come out, I think when you look at the treatment, obviously anything one can do as a provider to help reduce the attacks for the patient. Oftentimes we talk a lot about lifestyle and healthy eating and many other things. In the episodes of cluster, it's a little bit tougher to find that perfect remedy or the cocktail. So we often and historically have used a calcium channel blocker, verapamil, for cluster prevention. This is also used in migraine, but it tends to be the one that has the most benefit in patients with cluster. We'll use steroids or prednisone. Rarely we'll use lithium because now we have other medications. Lithium can be a very effective drug in some of these autonomic cephalgias, but one must have blood work and EKGs, and it requires a little bit more monitoring. And then nerve blocks can be used. Even for prevention, we'll sometimes use a low dose of an ergotamine, say like a low dose of 1 milligram twice a day. It's interesting in the patients who have cluster, if they use it daily, we haven't seen the phenomenon that occurs in migraine with medication overuse because it's a different mechanism. But again, melatonin may be something else that's used at higher doses, 5 milligrams to 10 for sleep at night to impact that hypothalamus and that circadian rhythm. But of the most exciting news is we actually have a very specific FDA approved drug now for the treatment of cluster. It's in the family of the calcitonin gene related peptide monoclonal antibody antagonist. What we know about this is that there's also a release within that trigeminal complex of CGRP, which is a protein that elevates during these attacks in that neurotransmitter arena between the synapses. The study was very low volume in population because this is not a very frequent diagnosis. And because of the episodic nature, the patients who got enrolled, they had up to a year to have cluster. They had to meet a specific criteria and then to be able to treat with the medication for long enough duration. So in average, I think in the clinical trial, it was about 50 patients in placebo and about 50 in the treatment trial. But it was enough to reduce the attack frequency and the days of cluster to actually get authorization. It's also interesting for those folks out there who may have migraine. You'll recognize what galcanezumab is. It's called Emgality. This is a very different dose that we use in cluster. The 300 milligram dose was actually studied before they began looking at the use of this medication in migraine. So for migraine, it's a 240 milligram loading dose and then 120 milligrams every month thereafter. This is 300 milligrams. It's 3 separate syringes of 100 milligrams. You use it during the cluster cycle. And once things quiet down and you feel pretty confident that the cycle's over, you can cease using it. If you have respite again for more than 3 months and the cycle comes back, then you can easily enough restart the treatment. When we talk about rescue or abortive treatment for cluster, the first line is a high flow oxygen, 10 to 15 liters of a non-rebreathing mask at the onset. Typically aborts it for you use it for about 10 to 15 minutes, and that's almost always indicative of rescue and relief. It's not always that convenient, however, to have an oxygen tank or an e-cylinder, something we don't like people to drive around in their cars with because they become a little trajectory as well. So we have to be careful about how people use that. The other thing is that if you can't use the high flow oxygen or it doesn't work, we do have medications to abort the cluster. Sumatriptan injection is the one that's been FDA approved at a 6 milligram dose with a maximum of 12 milligrams in 24 hours. Obviously, that's wonderful if you only get 2 of the attacks per day. But again, if people can have up to 8 attacks during 1 day's worth, you can't overuse this medicine. They also come as lower doses of 3 and a 4 milligram, not quote approved for the cluster treatment, but for some patients, a lower dose is as effective, and then they have a few more doses to navigate throughout the day if they need it. If they're not a fan of using injectables, then the Zolmitriptan nasal spray 5 milligrams is also approved for a cluster respite with a maximum of 2 of those doses or 10 milligrams in 24 hours. I put a little asterisk here just as a reminder that you can't use one triptan within 24 hours of each other. And also if a patient's taking an ergotamine as a preventive, then you can't use a triptan at all because one is venoactive and one is vasoactive. And one would assume we don't want to completely clamp down all vessels. So in other ways, we will sometimes use steroids or prednisone to block and stop an acute cycle. Nerve blocks in the occipital foci will also be used. And then this cartoon picture down here is what's called a gammaCore. And it's a vagal nerve stimulator. And so what it does, or the Sapphire, is you crank it up enough onto your neck until you sort of feel your little jerk of your chin. And then you give it pulse doses to treat acutely for the cluster attack. It's not exactly comfortable either, though patients will tell you that if it works, they'll put up with the pain and that triggering of that electrical impulse as well. I just wanted to show you a couple of pictures of what a non-rebreather face mask looks like. So here you can see it's a mask. There's little vents here that breathe out, and then this is a reservoir bag. There is a website that's the clusterheadaches.com. It's both a patient support group. They don't claim any quote unquote medical knowledge to sell you anything, but they also have this cluster kit that is a different kind of a non-rebreathing mask. That's about, I think it's about 25 bucks online, that hooks up to an oxygen tank as well. And the main thing to remember about oxygen tanks is home concentrators often don't get high enough on the volume to deliver. We mostly use those for low dose cannula that you'll see people who need just a couple of liters. So typically those big tanks or the M99 tanks that are pretty massive are what you need to do to have on hand to get the full flow of oxygen. There are a few studies that have been done in surgery. An occipital nerve stimulator is one device that can be implanted in the back of the head. The other would be the deep brain stimulator, or what's known as DBS. You often see that used in Parkinson's. There's been some trials also for severe refractive depression. What they do is they place some electrodes into the hypothalamus for electrical discharges. They have a little remote control generator so you can crank up or dial down when you're not having a cluster cycle. In all of my years of practice, which is a little close to 30 now, I think. I don't have any patients that with cluster that have either one of these devices or have had this done. But it is done. And there are larger cluster centers. The UK has a large cluster following. So I can stop for just a second in case anybody has a question specifically to cluster before we move on to the autonomic cephalgias. Anybody in the chat? I don't know if I can see the chat. I don't know if I'm smart enough to see the chat. Okay. Well, we'll just keep going. So the trigeminal autonomic cephalgia. So again, as you remember with cluster, trigeminal being that first, second, and third division of the face. Autonomic meaning you get these sensations of flushing, sweating, droopy eye, swollen eye, tearing, runny nose. So think of that sensation happening with these different kinds of headaches. So a paroxysmal hemicrania continua, SUNCT and SUNA. And those are very specific headaches that are also indomethacin responsive. There are other headaches down below that we'll get to as well that do not have autonomic features, but in some instances may respond to indomethacin. Trigeminal neuralgia is not one that is typically indomethacin responsive, but I wanted to put it on here just as a quick capture to know that there's other headaches that are out there that have some of these features, and then the ones that don't have the features. So interestingly enough, when we talk about paroxysmal hemicrania, this is typically seen in a woman. So it's not uncommon that I may see a patient in headache clinic who tells me they have cluster because of these features, and their prior provider had recognized that, oh, this is an autonomic headache, it must be cluster. But in fact, this is the diagnosis that we often see with women. And you'll notice the difference of the duration, right? So cluster episodes of 15 minutes up to 150 minutes. In paroxysmal hemicrania, meaning it's paroxysms of pain, it's coming and going, and very severe. Also happens above the eye, in the temple, or some combination of that, but only 2 to 30 minutes, and usually a minimum of about 5 times in a day. They also occur, so ipsilateral means the same side, that you might have that redness of the eye, tearing, runny nose. So very similar symptoms, as you can see, that may occur in cluster, with the exception of the predominant sex that's affected and the duration. But absolutely, these patients we see respond to indomethacin. Of course, someone's going to say later in the talk, so I'll abort, and that is, but what if I can't take an anti-inflammatory? I've had a gastric bypass, I've had a bleeding ulcer. Then we do use other medications to treat these headaches, but from a diagnostic perspective and just to understand the grasp and the depth of these headaches, that's what we're talking about specifically today. Again, just like cluster, you can have episodes of paroxysmal hemicrania, or you can have a chronic episode lasting more than a year and not remitting for less than a 3-month period. Okay. The other headache that's similar, and again, probably about a 1-to-1 ratio of men to women, is hemicrania continua. The difference of this is it's persistent. So there is no pain, remit, and very much the same story, though, that we would see with those autonomic features. Interesting as well is that sometimes in the hemicrania continua, you may have patients with migraine symptoms, light sensitivity, sound sensitivity, and it would only bode to reason that if you've got enough stimulus that's noxious to the face, pretty soon you're going to be pretty irritable. But lights and sounds are going to be obviously not what you want to have around you all the time either. This is a long sentence of a title, but it stands for short-lasting unilateral neuralgiform headache attacks, otherwise known as SUNCT or SUNA. And these are seconds to minutes. So again, as you categorize every different type of headache that occurs as an autonomic feature, the real standout difference is, of course, the length of time that these pains hit. It's also interesting. It says that, you can have this in the trigeminal distribution, which would be all 3 parts, but anywhere from 1 second to 600 seconds. Single stabs can be a series of jab, jab, jabs. You might even have what we call that sawtooth pattern. But again, it's a very debilitating headache. Typically, at least 2 bouts of these episodes for a week up to a year, can have pain-free times for episodic. Chronic is obviously static with less than a 3-month respite. Again, for this, we talk about treatment being indomethacin, but the other treatment, if they're not responsive or can't take it, is actually IV lidocaine. And we do have a wonderful partnership with the pain management group at the university that can help facilitate for some of these refractive patients the IV lidocaine, because it's not done in a lot of places. And then really the difference between SUNCT and SUNA is that on SUNA, you either have one or neither of the tearing or the conjunctival running nose. Oh, sorry, it should be redness and tearing, excuse me. But you might have other features of that jabbing, stabbing headache. And just for the sake of knowledge, there's also what's known as a primary stabbing headache. So I reference what's at the very bottom here on the slide deck called the ICHD3. Oh dear, I've done something now. There we go. So the ICHD3 is the International Classification for Headache Disorders, and this is the 3rd edition. If you can imagine, it's about 186 pages. And for those of us who are headache specialists, or otherwise known as a little bit geeky, it breaks down every single, for the most part, every single headache type one can imagine, both primary headache disorders, which we're talking about now, and secondary headache disorders, which can be post-stroke or from brain tumors or other reasons for headache. And just for the sake of keeping things a little bit simple, I put this graph together just to, again, give you the frequency that you expect throughout the day of the different autonomic cephalgias, how long those spells last, what's the quality of pain, some of the typical treatment, and ballpark of what age you would expect to see, as well as the gender. And because hemicrania continua is just a chronic headache, again, that's more of a 1-to-1 ratio for the gender. Okay. Now, this is a really special kind of headache. This is known as HYPNIC headache. So HYPNIC headache, otherwise known as an alarm clock headache, it often occurs usually about the 6th decade of life. It can happen in younger people as well. Because I'm almost 60, I say younger people. What the heck am I thinking? So it can happen in those other kids. But typically what happens is you go to sleep and then it causes awakening. And pain can last for 4 hours, doesn't actually have any notable characteristics other than usually a typically severe pain. But it's interesting in that it's right after you've gone to bed within about an hour or so, you wake with this pain. And the treatment for this headache is either lithium, caffeine, sometimes melatonin, and or indomethacin. As I mentioned earlier, lithium's a little bit tricky because of the EKG and the blood monitoring. And because this is typically in patients over 60, we often find that they're on other medications, and we want to be very thoughtful not to get in the way of any drug-drug interactions. So the first choice I go to if somebody tells me about HYPNIC headache or describes that headache to me, because again, it doesn't have autonomic features. So you can see how a patient might be reading, and because their headache happens at night in a cycle, they may think they have cluster. But then if you read further, the HYPNIC headache doesn't come with any of those autonomic features. So caffeine seems incredibly counterintuitive to treatment. And yet a little caffeine, whether it's a Mountain Dew before bed, whether it's, avoid the calories, you can just take a half of a caffeine tablet, say a half of 100 or a 200 milligram dose. And usually that doesn't keep people awake from the caffeine, but it actually prevents the headache from waking them from sleep. It's a very fascinating diagnosis, not super common, but again, I think part of why the enjoyment comes from a headache clinic for me just practically speaking, is that there's so many different variables about headache that it isn't just headache soup and, oh, that's your problem, you just need to sleep better. Well, my goodness, they are not going to sleep if they keep waking up after they've gone to bed for the next 2 hours. So again, a careful history and thoughtful presentation about the patient and what they're giving you when you're listening to their story is really important. There's also what we call a cough headache. So as one would guess, that's associated with cough or bearing down or straining pressure. And it can be be acute and short. The main issue is if somebody's coming to you even in their 20s and 30s with a new onset cough or Valsalva headache, you're typically going to image them. We almost always say a new headache in anybody over 50 will oftentimes earn an image right away just to make sure we're not missing out on anything. But in this event, this is an atypical headache presentation. And usually it's brought on in association with coughing and straining, but it's sudden, it's boom. And it doesn't last very long. Again, it can be just as brief as a hit. And some people say like they just drops them to their knees. It can even last up to 2 hours. And as you see, I put here that you have to have consideration for any underlying disorders. So a Chiari malformation, for instance, is where the posterior part of your brain, or what's called the cerebellar tonsils, sag down a little bit. And so when it sags and you cough, you get that instant spurt of pain. I had a patient who used to do wind sprints when she would get those headaches from her Chiari because it would reduce the volume and the pressure in the head. It's just not a way to live a great life. So she did have that Chiari decompressed. But also low pressure headaches, again, some of that sagging posterior part of the brain, or in fact, if there's a space occupying lesion. So obviously, if it's a primary cough headache, we're going to rule out that there's anything structurally as an explanation. And then if not, then we'll pre-medicate people or treat them with a little anti-inflammatory in advance as a prevention. Not that you can predict when they're going to get a cough. So, and then it's interesting as we talk about a primary exercise headache. So again, if you're a patient who has different types of headache, as most people have more than one type, you may have an exercise-induced migraine. And that is very typical. You start to exercise, or at the end of the exercise, almost like a letdown, you'll get migraine type pain. With a primary exercise headache, it's generally just precipitated by any kind of exercise, again, in the absence of intracranial disorders. But oftentimes the criteria is that it's occurring only during or after strenuous physical exercise, lasts less than 48 hours, and then it resolves. With that kind of headache, we'll sometimes pre-treat. If they know they're going to go exercise, then we'll give them some indomethacin or 500 naproxen about an hour ahead of the activity as a way to mitigate that trigger. There is, under this bullet point, where you can also see this in sex or orgasmic headaches, known as an explosive headache. Again, when that happens, because it's more of a crescendo effect, always want to make sure that there's no vascular impairment, ruling out that there's been any subarachnoid hemorrhage or any other vascular anomaly that may explain that. And the one thing that's also down here is to make sure that this is not in conjunction, what we call RCVS, or reversible cerebral vasoconstriction syndrome. This is oftentimes an abrupt onset headache. It's most often, I would say, when I've seen it, both associated with hypertension, and it's very severe, may present almost like a TIA or a mini stroke. But people who have the diagnosis of RCVS are oftentimes kept away from any further vasoactive drugs like the triptan family. We try to even avoid some of the serotonergic drugs like the antidepressants, because it can be very specific in re-triggering and refiring that same experience. So oftentimes in RCVS, we'll use verapamil as a way to quiet down the vascular system so that you have less irritability for that flux, and also to help control the blood pressure. I mentioned earlier about trigeminal neuralgia, and this again does not have autonomic features, to be clear, but it's a severe unilateral pain, and this is much more of an electrical shock. It can be shooting or sharp as well. Typically in one branch of the trigeminal system, it's rare that you would have all three branches impacted. It's only about 4 to 5 people per 100,000. Again, seconds to minutes. But you may have heard the old term called tic de la rue. It's triggered by noxious stimuli. So brushing your teeth, sometimes putting makeup on, if you get the wind on your face or too much touching of the face, that can be a very, very debilitating pain. When we look at trigeminal neuralgia, one of the things we often think of first in young people is to make sure we image them looking for any demyelination or MS, for instance, and obviously any mass as well. But we're sometimes on imaging with an MRI and an MRA, which looks at the arterial vessels. There could be a little loop right around that trigeminal nerve, and that can explain sometimes if you get a little bit of pressure or exertion, that triggers and flares that up a little bit. We try as much as we can in trigeminal neuralgia to keep it conservative, with just medication if we can. Sometimes too, IV lidocaine can be helpful. But again, if the patients are just refractive, then usually a neurosurgical evaluation for possible decompression, they may wrap the nerve, and gamma knife or radio frequencies. There's a bunch of different modalities. The rough part is it's not a superb guarantee that if it works, it's going to stay away. Sometimes within about 5 years of surgery, it can come back. And in some patients I've had actually get it on the other side. It's not super common, but that can also happen. So I think that, the goal of understanding the different kinds of face pains, as we would call them tonight, and different kinds of headache is recognizing the structure from which they arise is typically the trigeminal complex, how it's innervated between receptors and neurotransmitters in the brain with serotonin, norepinephrine. We talked about the histamine effects. So those things all have a compilation of which affects pain in very different ways. So this slide that I have to talk about where does pain come from, I think that's really important that, for people who have headache, it's not a hard stretch to understand this. For people who are maybe the significant others of ones with headache, it's really hard for them to not grasp, like, well, why can't you just fix the headache? Like it's just a headache. When so often there's so many other layers that interfere and disrupt where pain comes from. So it happens in the arteries, in the dura mater, it happens in the brain itself, everything around the vessels, the skin, you touch your head, you feel sensitivity. Even when people have migraine, they may say, oh, gosh, even after my headache has occurred, it hurts to touch my face or it hurts to brush my hair. That's what we call allodynia or third order neuron pain that's also associated with the kind of headache that's occurring within that brain pain sensitive structure. So I think it's just the last part that I wanted to make sure we touched on is that it isn't as simple as saying, well, if you have pain coming from that trigeminal nerve, cut it, burn it, do something to it, because oftentimes things can regenerate and you can still get other pain. So making sure that one has the right diagnosis, I think, is most important before we go any further from that point. So I don't have anything else. I just wanted to make sure it's always difficult, right? Not being in person because I can't be as interactive as I'd like to be. But this is just some information for those of you who have underpinning of headaches, maybe have these other unusual autonomic features that come with your headaches, and know that there are treatments, and there are certainly newer treatments than we've had in the last couple of years, even for some of them. So with that, I'll close and open it up for